Hi everybody, welcome to Healthline. I'm Gregory Zarian. So summer is pretty much over. We are now stepping into fall, so that means you're going to throw on some sweaters. You're going to probably give yourself reasons why you're not going to be outside, why you're not going to work out, why you're going to give yourself this list of everything to become lazy. So here at Healthline, as you know I always do, I invite you to still get up, get out. If you have to throw on a sweater, throw on sweatpants, just get up and get out. You know, for the past couple of years we have been stuck inside. There is no reason now to be stuck inside. There's more reason to get up and get out and do more things. Find a buddy, find a partner, find a wife, best friend, whatever, and just get your lifestyle on. Our mission here is to have you be as healthy and active as possible. And as you know, I love giving you as much information as possible. So today the conversation is all about colorectal cancer. How to prevent it, signs and symptoms, and what you need to know to keep yourself healthy. And you know, you see a Diet Coke and you see a Coke. When you see the benzo in that, do you have any idea what that means? Well, I thought I would let you know. So bringing us as a recurring guest from Adventist Health Glendale, one of our favorites, Dr. Avo Artinyan. And your specialty is colorectal cancer.
Surgical oncology, colorectal cancer.
And there's some great news since you've been here a couple years ago, which is?
So since I was here last, we've formed our own private practice multidisciplinary surgical oncology group. It's called the Academic Surgical Associates.
Congratulations.
Thank you. So we basically treat complex cancers of essentially the entire body. We have we have three, about to be four surgeons who treat cancer in a multidisciplinary way. So basically we have everything covered. Especially for GI cancer. So,
and you've been busy then, so a lot of people,
yes.
You know, some people were organizing their socks and learning how to make bread and do all these things during the pandemic. You were forming this amazing group that can save lives.
Yes.
You know, Doctor, as I did last time as well, I took a deep dive into statistics and just some of the facts. Excluding skin cancers, colorectal cancer is the third most common cancer diagnosed in the United States. And then before we started talking, by 2030, colorectal cancer may be the leading cause of cancer death in adults under 50.
Yes.
Last time you were here, this wasn't part of the conversation. What has happened?
The incidence of colon and rectal cancer basically is increasing in younger patients.
Why?
I think the last time we talked, the screening guidelines still recommended colonoscopy and general screening at 50. Now screening guidelines are for screening the average population at 45. And the reason is why. We are seeing an increase in the incidence of colon and rectal cancers, especially the rectal cancers, the ones that are lower in the younger population. Why?
Wait, let's hold on.
Sure.
We're going to keep the why as a little bit of a cliffhanger. So why do you think there's more occurrence for people under 50? Oh, I have ideas. More when we come back. Don't go away. Welcome back to Healthline. I am Gregory Zarian. So I'm going to start with a fact. The American Cancer Society estimates for the number of colorectal cases in the United States for 2022 are over 106,000 new cases of colon cancer and over 44,000 new cases of rectal cancer. What are we doing? And the new incidences of colon cancer we thought were for people over 50. They're for you under 50. Joining us from Adventist Health Glendale is Dr. Avo Artinyan. And the cliffhanger was why? And to me, since hosting this job for so long, my invitation to everyone to be as healthy as possible. Why are we taking a dip here, Doc?
It's a combination of things. So when we talk about cancer, everybody asks me the cause. You've asked me the cause of colorectal cancer before, and realistically, we don't know. But in general, cancer has two general causes. So one is related to you, the person, and the other is related to the environment. So with respect to any GI cancer, gastric cancer, colon and rectal cancer, the environment is what you eat. So presumably this increase is related to our diet and our changing diets.
So doctor, let me start off with when you said you.
Yeah.
Because I'm going to put a pin in the lifestyle and what we eat.
Well, I was referring specifically to your,
Oh,
but your family history, but
to me, to my family history.
but in general.
But to everyone's family
Yeah.
history.
Yeah.
So, if my father had colon cancer,
Right.
is there a guarantee that myself or my brothers would possibly get it? Does it give us a higher risk?
That's a great question. So, does it guarantee that you will get it? No. Does it put you at higher risk? The answer is yes. So when we look at colon cancers in general, so the 140,000 people who will get colorectal cancer, colon and rectal cancer over the course of the next year, about 5% of those cases will be hereditary, meaning they have some sort of genetic syndrome that we understand. About 20%, rough estimate, are cases that have a genetic component that we know about, so family history being one of them. And the rest, about 75 to 80%, are purely sporadic, where we don't understand or we don't know of a potential hereditary cause. So to answer your question, yes, a family history puts you at higher risk, especially first-degree relatives. So a parent is a first-degree relative, brother, sister, and relatives who have colon and rectal cancer before the age of 50. And once you're in that higher risk group, then we talk about all these screening guidelines. Your screening guidelines will change based on your risk.
So if there was colorectal cancer history in my history, just say my
Yes.
father, what does my screening guideline change to?
So if it's a first-degree relative, let's say, who had colon and rectal cancer at 50, let's say your father or your mother, then we generally recommend your screening to start 10 years before that incident case.
So at 40.
At 40. If you're...
And the same thing for men and women. Period.
Yes.
Okay.
So that's how it changes. You basically get thrown into a higher risk group, and we change the guidelines a little bit. All the guidelines we talk about and that are published are for what are called average risk patients.
And one thing too that I'm sure you remember me talking about too is ask your parents, ask your grandparents, ask your family about medical history. It's mandatory. You
Yes.
need to know these things. And just because there's colorectal or rectal history in my family does not mean I'm going to get it.
No.
It just means I'm more susceptible to it.
Yes.
Doctor, what are signs and symptoms that anybody is looking for? Because before we started, we said that it's kind of like a silent killer.
Right. So exactly, the silent part is key, because we don't want you to have symptoms when we discover your cancer. We want to discover it with screening. The symptoms tend to be what are called non-specific. They're not very specific to colon and rectal cancer. So changes in bowel habits, constipation, changes in the caliber of stools, rectal bleeding, which is also non-specific because a lot of people will dismiss rectal bleeding as hemorrhoids, for example. So the biggest ones are bleeding, changes in bowel habits, and once you start to get more advanced disease, then we see other things that we don't want to see: weight loss, and so on, fatigue, that type of thing.
When you said changes in stool, is it a one-off or is it consistent?
It tends to be consistent. So it'll depend on where the cancer is in the colon. If it's on the left side, closer to basically your bottom, if you start seeing that going to the bathroom is harder consistently, plus the caliber, the size of the stools change, and they stay consistently different or smaller, then that's a reason to start. It's not a reason to panic, but it's a reason to start thinking about getting checked out, essentially.
More Dr. Artinyan when we come back. Don't go away. Welcome back. Joining us from Adventist Health Glendale is Dr. Avo Artinyan. Doctor, I just want to be really precise in regards to, because I know there's a stool chart.
Yeah.
That you as doctors and physicians can really tell about how we are feeling in our health and our lifestyle through our stool. In regards to what you were saying, a change in stool habits, can you be a little more specific?
Sure. When we talk about stool caliber, basically throughout your life, you know the size of your stools, meaning how thick they are. If you have a cancer basically blocking the pipe, the stools will get thinner and thinner.
Okay.
So if they start to get what we call pencil thin, and consistently that way, then that's a reason to be concerned.
And as I was asking earlier, it's not so much, you could have a sporadic episode here and there, and that just it is what it is.
Yeah.
But when it's chronic, pay attention to it. Then you also said if there's blood in the stool, a lot of times it is written off as maybe it's a hemorrhoid, or I was exerting too much, or whatever.
Yeah.
How much blood in the stool are we looking at? Is it more of a consistent experience?
Yes, and there's no sort of good amount or bad amount.
Okay.
If you start seeing blood in the stool, you have to have an explanation. So sometimes, in younger people, we see blood in the stool. That isn't necessarily a reason to run to colonoscopy right away, as long as you can explain it. So a doctor sees you, says, "Hey, I see the source of the bleeding." That's it. But if it's not clear, or if there's any doubt, then you have to rule out something worse, so something higher up, like a colon or rectal cancer. But it should never be dismissed.
I love that. Are there blood tests that one can take for this as well, and urine samples, or is it more of a...
Yeah. So part of the screening, there's a few ways to do screening. One way we do screening is by testing the stool for blood, essentially. Okay. And we call that occult blood testing. Occult means we can't see it. So if you can see it, there's no purpose in doing a stool blood test because it's going to be positive.
Got it.
But when we do screening, we're looking for occult or hidden blood. And these are the common screening tests that we use starting at age 45. So one of them is called a FIT test. The other one is the old, what's called guaiac test. But both of them basically test for blood in the stool.
Is there any pain? Is there any nausea? Is there any fever? Is there any rapid heartbeat? Is there anything like that somebody should look for?
I would say once you get to that stage, then the cancers tend to be more advanced. Okay. So that's not what we're looking for. When you get to that stage, you're going to get checked out. What you're looking for are subtler signs, and frankly, we're hoping not to get to that point at all. Meaning, get screened when you're supposed to get screened, and without any symptoms.
So men without any history in their family. 45,
you start screening.
Okay.
And that can mean a variety of things.
So what does the screening look like?
So screening...
And this is for men and women,
yes?
Yeah,
for everybody. Okay. So there are a bunch of screening tests, but screening tests fall into two general categories. So one category is blood tests or stool tests that we talk about. And the other category are actual visual tests like colonoscopy. So the blood tests that we commonly use are called FIT tests. That's basically a chemical test for blood in the stool. Guaiac tests. We also have stool DNA tests that are a little bit more expensive. Unclear if they're any better. One of them is Cologuard, and it's advertised on TV. The visual tests are colonoscopy. They tend to be better because we can actually find a potential source, and we can biopsy it and do things like that. If you can't tolerate a colonoscopy, then we have what are called virtual colonoscopies or CT colonographies. Those are tests that we do with x-rays. Not as good as the standard colonoscopy, but better than nothing. So as far as which to do, there aren't any clear guidelines on, let's say, which test to do when you're 45. What we're trying to get is most people who qualify for screening to get some sort of screening as soon as possible when they qualify. So if you have a stool positive test, then you end up going to a colonoscopy, for example.
And then what is the space between colonoscopies? How many years do you recommend?
Yeah, so if you're doing colonoscopies, the general guideline is to do colonoscopies every 10 years, but if that's part of your general screening regimen. So if you're doing colonoscopies every 10 years, once you're screening every year, you should be doing some sort of stool blood test.
Okay.
So if your stool blood tests turn positive before 10 years, you don't wait 10 years to get another colonoscopy. You do your colonoscopy then.
And most people are so afraid of the colonoscopy prep.
Yes.
And I've had a couple of them.
Yeah.
You're going to be fine.
Yeah.
Truly, it's really nothing.
I mean, it's not pleasant, but it's not bad either at all.
No.
I've had a colonoscopy too, and it's.
Well, there's actually a bit of a clarity.
Yeah.
And as we were talking before we started filming about just a lot about gut health and what we put into our system, there's a mental freedom and a calm that I feel when I've done them, and there's a lightness to it that I don't feel so bogged down.
Let me put it this way: most people go and pay for colonic cleanses.
Sure.
You can think of a prep as a cheap colonic cleanse because that's what it is.
And in the process, we're going to be trying to save your life. So then, let's go back to what I put a pin in, doctor. Lifestyle. Since it is now for people below 50,
Yeah.
50 and below, what are we eating? And it goes back to what I was saying about the benzo and the conversation about a Coke or a Diet Coke.
Yeah. So in general, lifestyle. So as far as lifestyle risk factors, yes, it's what we eat. So, but there are a few other things. So number one, for every cancer that I know of, there are 2 risk factors that are pretty consistent lifestyle-wise: smoking, obesity. Risk factors for every single cancer, including non-GI cancer. So those are the 2 things that have to go, basically.
Okay, we're going to put a pin in this, doctor. More Dr. Artinyan when we come back. Do not go away. And maybe have a glass of water. We'll see you on the other side. Welcome back. Adventist Health Glendale is one of the Health Grade's America's 100 best hospitals for cardiac care and has been named among the top 5% in the nation for overall cardiac services. Joining us from Adventist Health Glendale is Dr. Avo Artinyan. Doctor, so before we left, you said obesity and smoking contributes to all cancers. Can you really be direct with that? Because there's a lot of people I know that smoke, and I would love for them. And, you just don't wake up and you're obese. So you participate in your health and your unhealthy choices.
Yeah, so there's not much more to say. Smoking and obesity basically is a risk factor for almost every cancer, heart disease, and so on. So those 2 are low-hanging fruit. They need to go.
Okay, so we have obesity and smoking.
Yeah.
So those are 2 things. No.
No, and those are low-hanging fruit. But the third environmental factor, or the factor that we can change, is diet. And with respect to colorectal cancer and diet, we talk about the foods that are essentially preserved, and preserved red meats. So anything that's cured, fermented, smoked, salted is basically considered a class 1 carcinogen for rectal cancer. It's almost like having a cigarette. If you have a piece of bacon or a cured hot dog, it's like having a cigarette for your gut, essentially. So those are the things that you can start to phase out, and even places like Whole Foods, Trader Joe's, you see them phasing out cured hot dogs. You have these non-cured items now, and that's the reason.
But then earlier, I was saying something earlier about the word benzo in Diet Cokes and sodas.
The other thing that I've noticed is I've started to read labels more, and there are a lot of preservatives that we don't necessarily mention. And one that I brought up with you is what's called sodium benzoate, potassium benzoate. And now the FDA says that it's safe, but these are chemicals that turn into benzene compounds when you eat them. The doses are small.
But after 30 years.
Yeah, so after 30 years, who knows what happens. But in any case, I don't want Coca-Cola coming after me. But
this is in your medical experience.
So I don't know how much that contributes. But when you look at these chemicals in all our foods, these preservatives, there's no way for us to know whether these have contributed or not. All we know that younger people are getting colon and rectal cancers and other GI cancers, and it's unclear why. But when you look at our diets over the course of the last 30, 40 years, we've increased our meat intake, and the food industry has become an industrial industry. We have organic foods, but it almost feels like half the stuff we eat is basically made in a lab.
Sure, and it's also a lot more fast food.
Yeah.
So, doctor, bottom line is you're thinking eating more of like a Mediterranean type diet, more greens, more.
Yeah, I'm saying look at labels, try to basically do without chemicals, especially if you can't pronounce them.
Yeah.
Try to do with foods that don't have them, and try to stay away from preserved meats.
Okay.
And red meats and things like this are fine. Everything in moderation is okay.
I love that. And then lots of exercise, lots of getting up, getting out.
Yes.
Talk to us about, so somebody is diagnosed with colon cancer.
Yeah.
What surgical treatments are there?
So we like to think of the treatment as multidisciplinary and holistic. That's why we were talking about our multidisciplinary group. So traditionally it's just been surgery for colon cancer, but things are changing a little bit. For rectal cancer it's a little bit different, but a lot of these novel therapies are coming through now that are going to change the paradigm, so to speak. meaning bottom line standard of care for colon cancer right now is if it's curable, surgery plus some sort of chemotherapy if you qualify. For rectal cancer, generally it's some sort of chemo, radiation, or some combination of chemo, radiation, and surgery. Things are changing. Over the course of the next 10 to 15 years, a lot of these diseases, a lot of these cancers, including colon and rectal cancer, are going to become less surgical, meaning we're going to be able to treat them medically. And
when you say medically, what does that mean? More
with medicine. So
Wow.
one of the buzzwords, and I had basically everybody that I know calling me a few months ago because there was an article or there was a research study that showed that rectal cancer, or at least some rectal cancers, can be cured with immunotherapy.
Okay. And when you say immunotherapy, what does that mean?
They're basically, you can think of them as chemotherapies that basically utilize the immune system to some degree, our natural immune system, or target our immune system. And even with colon cancer, although it's not sort of common knowledge, this is coming for colon cancer too, but only unfortunately a subset of colon cancers. But as the research sort of advances, a lot of these cancers are going to become less and less surgical and more medical, so to speak.
But that also does not mean that you do not pay attention to what you eat. That does not mean that because a lot of people think, if I can take a pill, I'm okay.
Yeah.
It does not mean that you do not do your job. And the agreement with you and me as a doctor is you do your job, I'll do my job, which is adhering to all the advice.
Yes. And that's not to say that you're going to get a pill and you're going to be cured. The best way to cure something is not to have it at all.
I'm going to leave it with that. Doctor, thank you so much for coming back. I appreciate it. So you heard from Dr. Artinyan. Obesity and smoking. 2 that participate in cancers, period. You are the captain of your own ship. If there's something that you are questioning in regards to you and your body and your health, talk to your parents, talk to your grandparents, talk to your family. Then, do not self-diagnose. Make a phone call to your doctor, because the best news is, hey, you're okay. The worst news is, hey, you know what, we can treat this and we caught it in time. Colon cancer does not have to be a death sentence. Rectal cancer does not have to be a death sentence. It just means you have to have a conversation. If you are suffering from any signs and symptoms that we discussed, change in stool, blood, pain, any of that, pick up the phone, call your doctor. Remember, the most important conversation you're going to have is about you and your health. So why not start talking now? Take care. We'll see you next time.